Greetings, everyone. I'm Dr. Richard Childs, and today I'll be talking about CAR T-cell therapy and hematopoietic stem cell transplantation, and we'll talk about the current status and use of CAR T-cells and stem cell transplantation and some of the future directions these therapeutics are going in. So first, I'd like to focus on CAR T-cells, what they are and how they work. As a quick overview, chimeric antigen receptor T cells, or CAR T cells, are a living drug, basically, that utilizes the patient's own immune cells to target their cancer. There's a number of components for manufacturing CAR T cells that includes, as you see on the slide, collecting blood from the patient to extract the T cells from their body, sending this blood to a manufacturing facility where the T cells are then isolated from the blood and engineered to express specific receptors that target antigens that are expressed on the cancer. Once these cells are genetically reprogrammed, they're then grown in the laboratory or in vitro. They're then shipped back to the patient and then infused intravenously into the patient. Once they get in the patient's body, they grow and proliferate, and then will hopefully encounter the malignant cells, bind to them based on their chimeric antigen receptor, targeting a specific antigen expressed on the cancer, and then kill them. So let's go into a little bit more detail in terms of how these cells are actually manufactured. So patients that are candidates for CAR T cells undergo a procedure called apheresis, where they get a couple of IVs put into them and have their blood collected in a machine that enriches for the T cell component of the mononuclear fraction. That mononuclear fraction is sent to the cell production facility, where the gene that reprograms the T cell to express the chimeric antigen is, in most cases, in a virus, either a retrovirus or a lentivirus. That virus is exposed to those T cells, and over the course of about 1 to 2 days, that gene that is in the virus that contains a chimeric antigen receptor and codes for it, at least, is introduced into the T cell, then integrates into the chromosomes of the T cell and is now expressed so that the chimeric antigen receptor is translated and then comes to the surface of the T cell and is now basically like a combination of an antibody bound to the surface of a T cell and is capable of recognizing the target antigen. Once those cells are manufactured, they're grown up in the laboratory, typically for a total cell production time point of somewhere between 8 to 12 days. They can then be frozen viably. Patients usually will get some chemotherapy before they get these CAR T cells to try to knock down any immune cells that might suppress these cells from growing in the body, so that the CAR T cells will have a proliferative advantage. Those cells, after the chemotherapy, are thawed down and then infused to the patient, and hopefully will encounter the tumor and eradicate it. One of the dominant target antigens of CAR T cells is called CD19. CD19 is a B cell differentiation antigen. It's expressed on a significant percentage of B cell malignancies. This includes diseases like leukemias and lymphomas, mantle cell lymphoma, follicular lymphoma, diffuse large cell lymphoma, and acute lymphoblastic leukemia are some of the more common malignancies that are targeted going after CD19 with CAR T cells. It's the common expression of this antigen on cancer cells that makes it such a good target for B cell malignancies. You can see this cartoon here, the T cell with the chimeric antigen receptor, this scFv, single chain variable fragment, coming in, binding to that CD19, and then activating the T cell and inducing it into signaling to kill the target antigen. CD19 CAR T cells now have been around for about 10 years. The first study with their use showed really dramatically surprising activity in patients with acute lymphoblastic leukemia. This study published in the New England Journal of Medicine, reporting patients that had relapsed leukemia having a complete remission rate of 81%, and an event-free survival rate at 12 months of 50%, really remarkably high in a population that had relapse refractory disease, where survival is often measured in just a couple of months. And the remarkable thing was that not only was the response rate high, but that such a high percentage of patients were achieving a complete remission. And some of these patients had prolonged disease-free survival, raising the possibility that a single infusion of CAR T cells for some patients may have actually been curative. That CD19 target antigen has now moved from that being the only target antigen to additional antigens that are expressed on B cells, including an antigen called BCMA, which is expressed on a majority of multiple myeloma cells. This study published in the New England Journal of Medicine in 2021 showing that BCMA is actually a great target for CAR T cells. Here, patients with very advanced multiple myeloma, having failed a median of 6 prior lines of therapy, having an incredibly high response rate with a single infusion of BCMA CAR T cells, 73% complete response rate, with 33% achieving a complete response. And some of these patients actually becoming MRD negative, where you couldn't detect any evidence of the myeloma at all. Some of these patients had a complication called CRS, cytokine release syndrome, 84%. And we'll talk a little more about that later, but this is one of the most common toxicities of CAR T cells. Fortunately, most of the patients experiencing this complication had relatively mild to moderate CRS, but dramatically high response rate in patients with very advanced multiple myeloma. More recently, CAR T cells targeting CD19 have been tested in patients that have relapsed or refractory large B-cell lymphoma, in a cohort that has a particularly poor prognosis with conventional chemotherapy or autologous stem cell transplant. In this study, patients that had large B-cell lymphoma that had relapsed within 12 months of receiving primary therapy were then randomized to either get standard of care, which is typically an auto transplant for these patients, versus getting CAR T cells followed by an auto transplant. And you can see here that the patients that got an auto transplant, got chemotherapy followed by an auto transplant, did much worse than the patients that got CAR T cells followed by an autologous transplant. Now establishing a new standard of care for patients with early relapsed diffuse large cell lymphoma. So another use and a newer use for CAR T cells for patients that have early relapse and the worst prognosis with conventional chemotherapy. If we look at current uses of CAR T cells in the US, you can see that there are currently 6 FDA-approved drugs for B-cell malignancies and for multiple myeloma, and I've listed some of the drugs here. Some of the drugs are, targeting the same antigen, BCMA or CD19, but are targeting a different part of the protein, something we call an epitope, and also may have signaling domains that are expressed that are different from one CAR T cell to the next, and that's why they're considered distinct drugs, and they have different names and different efficacy and different toxicities associated with their use. But you can see in terms of approval, these CAR T cells are approved for diffuse large B-cell lymphoma, follicular lymphoma, acute lymphoblastic lymphoma, multiple myeloma, and mantle cell lymphoma. You can see over the last 8 years, there's really been an explosion in the use of CAR T cells here, going up to data from 2021. I don't have the more recent data, but you can see from something that was really a very boutique, rarely used therapeutic intervention with only a couple of hundred patients being treated back in 2016, but to where in 2021, close to 6,000 patients being treated. So this has now really become an accepted, highly effective therapy for treating patients with B-cell malignancies and multiple myeloma. And then when we look at the categories of diseases that CAR T cells are being used, you can see that there is an evolution in indication that's occurred over that time frame, from early therapies being primarily focused on patients with acute lymphoblastic leukemia to 2021, where the dominant indication is for patients with large B-cell lymphoma, followed by acute lymphoblastic leukemia, mantle cell lymphoma, and then a smaller use in follicular lymphoma, and then an increasing and steadily increasing use in patients with multiple myeloma. And it's almost certain that within a short period of time, we'll have CAR T cells targeting other antigens expressed on other cancers. And we expect that the number of these CAR T cell products that are utilized will continue to increase. The number of malignancies that will be effectively targeted with these CAR T cells, we also believe will likely increase as well. So one of the questions that remains to be answered is, well, if you get a CR, complete response, are you actually cured? Or is this just buying you some time, and does it give you a window to take patients to maybe something that is a more definitive and known curative therapy, like a bridge to an allogeneic stem cell transplant? Right now, the data looks like that for some patients, they can actually be cured with a single infusion of CAR T cells. Here, seeing a little girl who had acute lymphoblastic leukemia that was disease-free in 1 year, and nobody knew, was that going to be enough to cure her? And here she is 8 years later, disease-free. And usually with these types of aggressive leukemias, if you're going to relapse, you're usually going to do that within the first couple of years. So we have increasing evidence now as time goes and patients go longer and longer that CAR T cells for select individuals may have the potential to actually represent definitive and curative therapy for them. And we're seeing trials that are now starting to bring CAR T cells up earlier in terms of the period when they're being used, and rather than reserving them only for patients that have relapse disease or refractory disease, but in investigational trials looking and seeing what happens if these cell populations are used at the initiation of therapy. Would that lead to a higher long-term disease-free survival rate? And now people are even starting to ask the question, for some patients, is it possible that they can avoid chemotherapy altogether and just be treated with immunotherapy? And I think we'll see more and more studies that will explore that question. Some of the challenges with CAR T cells that are listed here, sometimes it's difficult to get enough T cells from the patient because they've received so many chemotherapeutic agents to actually manufacture the CAR T cell product. Sometimes the tumor can downregulate or have antigen loss that can occur to where that antigen that's being targeted is no longer expressed, and the chemotherapy may be able to evade the immune response. There can be toxicities, cytokine release syndrome, or ICANS, that are from cytokines that can cause low blood pressure and can cause problems with anything from rashes to neurotoxicity. And we can treat those effectively now with IV medications to avert severe CRS types of symptoms. We grade these cytokine release symptoms depending on severity, including blood pressure and how low the blood pressure goes, and the need to support blood pressure with IV medications. And there's a drug called tocilizumab that targets IL-6, that when patients develop fever or low blood pressure, is highly effective in reversing that CRS process. So I'm now going to switch to stem cell transplantation. moving away from CAR T cells. There's two types of stem cell transplants. An auto transplant where a patient has a malignancy where their hematopoietic stem cells are collected through a mobilization procedure and then frozen, and then the patient gets high-dose chemotherapy to try to eradicate every cancer cell, but it wipes out the bone marrow in the process of killing all the cancer cells, and then you can rescue the bone marrow by thawing the stem cells that were previously collected and fusing them back into the patient. Auto transplants represent first-line therapy for patients with multiple myeloma, where they've been shown to prolong progression-free survival and overall survival. And they also represent second-line therapy for patients that have relapsed Hodgkin's and non-Hodgkin's lymphoma, where they've also been shown to prolong survival in non-Hodgkin's lymphoma and disease-free survival in Hodgkin's disease. Allotransplants are different in that the patients are receiving a stem cell source that's not from themselves. It's from an allogeneic donor. And in this case, the patient still gets that same conditioning regimen, but the stem cells are collected from the allogeneic donor, either a relative, fully matched, half matched, or from an unrelated donor infused into the patient to rescue their bone marrow function. You can see that the number of allotransplants and autotransplants performed annually continues to slowly increase. So these are very commonly used procedures, more than 12,000 autotransplants performed in 2020, and more than 8,000 allotransplants performed in 2020 in the United States. In terms of these stem cell sources, we can collect the stem cells from our allogeneic donors from their blood by mobilizing their stem cells with a hormone called GCSF, injected for 5 days, and then put the donor on a machine, apheresis machine, and after about 3 to 4 hours, collecting stem cells and freezing them down for use. We can also collect stem cells from the donor's pelvis through something called a bone marrow harvest. Or you can even collect stem cells from the placenta. These are called umbilical cord blood stem cells, and they can be used also to rescue the bone marrow function of a patient undergoing this approach. One of the things that's different between an allotransplant and autotransplant is that in an allotransplant, we give these patients high-dose chemotherapy, the preparative regimen to try to wipe out all the leukemia cells. But one of the things that we know is it's very difficult to eradicate every single cancer cell. So any one of those surviving cancer cells potentially could cause disease relapse. But when we rescue the bone marrow function of these patients with the allograft, we transplant not only stem cells, but we transplant immune-competent lymphoid tissue, T cells, from that donor. And these T cells are able to mediate this effect called graft versus tumor, graft versus leukemia, and kill any of those small populations of surviving cancer cells. And that's what is the really powerful immune effect that occurs after an allogeneic transplant. They can take a person with chemotherapy resistant disease or even refractory disease where we can still cure them because that immune effect is so powerful and potentially curative. So can this graft versus tumor effect alone cure patients with leukemia? We have some diseases where patients have disease completely refractory to any chemotherapy. Here, a woman that had mycosis fungoides, a T-cell lymphoma, that got a transplant and had tumors all over her body that progressed after the conditioning regimen, but those immune cells that were transplanted into the patient could mediate an anti-tumor response. And you can see 7 months after the transplant, these lesions are slowly disappearing, becoming flat without receiving any further therapy, just the immune cells of that donor circulating in her body. And here she is 10 years after the transplant in complete remission, with a refractory disease that was associated with a survival less than 6 months, doing fantastic. And here she is in 2022, doing exceptionally well. So this is to show you that 17 years after that transplant, this patient is disease-free and is almost certainly cured of her lymphoma through this graft versus tumor effect. There's different types of transplants. There's transplants that use high-dose chemotherapy or myeloablative chemotherapy intended to try to eradicate all the cancer. And there's transplants that use reduced intensity conditioning, where the conditioning is mostly to try to get engraftment of that donor immune system. And then you're really much more hanging your hat on that immunologically mediated eradication of the cancer through the engrafting donor T cells. So a low intensity transplant has a lower risk of TRM or transplant-related mortality, but is associated with a higher risk of relapse for some cancers. High-intensity transplants are associated with a lower risk of relapse, but are more toxic and are associated with a higher risk of transplant-related mortality. The advantage of low-intensity transplants is we can do them in older patients. So patients that historically 65 and older were not eligible for a allogeneic transplant because the rate of transplant-related mortality was so high. You can do reduced intensity conditioning and you can have excellent transplant outcomes. And we can see now that, almost slightly more than a quarter of the patients that we're doing allo transplants on are over the age of 65. And that's just a testament to how much safer these procedures have become, allowing this therapy to be applied to a greater percentage of patients. And that's one of the things that I wanted to just make everybody aware of, is that transplants have improved dramatically over the last 20 years in terms of safety. Showing here day 200 NRM or non-relapse mortality really dramatically increasing from over 20% back in 2003, 2007 to about 10%. So transplants are getting safer, and that is translated to survival in patients with diseases like acute myelogenous leukemia being much better in conventional cohorts compared to older cohorts. So why are we still doing these allo transplants when we've got all these targeted therapies for patients that are able to induce long-term disease remissions, like tyrosine kinase inhibitors for CML? For some diseases like AML, ALL, and MDS, the only curative therapy that still exists for these patients is an allogeneic stem cell transplant, including for some patients with non-malignant diseases like sickle cell anemia and aplastic anemia that's relapsed and has become refractory to immunosuppressive therapy. Allogeneic transplants, even though they are not targeted, are capable of curing patients even with the most advanced diseases. And we know that the patients that do best with an allo transplant are those that are brought to transplant earlier. So in patients with AML, for instance, the best outcomes are achieved in those that get a complete remission with chemotherapy and then go on to a consolidated allogeneic transplant, and where the overall probability of long-term survival is the best. So just the last couple of slides are, what are the requirements to get an allogeneic stem cell transplant? The first is that you have to have a donor who can serve as a source of stem cells. In the old days, we used to do most of our transplants from HLA identical siblings. Siblings inherit these tissue antigens in a Mendelian fashion, so the chance that any one sibling is going to be HLA identical is 25% per sibling. In the US, family sizes are getting smaller, so it's harder to find HLA identical siblings. But if we look at anybody that gets a transplant, you can see roughly of everyone we transplant, about 20% get a transplant from an HLA matched sibling. Another 50 to 60% are getting their transplant from the unrelated registry, where we have these volunteers that have been HLA typed, where in some populations you can find an HLA matched donor in the range of 30 to 60%. And then for people that we can't find a matched unrelated donor or sibling donor, we have alternative transplants, which include cord transplants, where we can get away with tissue antigen mismatching, or a haploidentical transplant from a half-matched family member. Any sibling would have a 50% chance of being a haplodonor. Any parent would be, by definition, 100% chance of being a haplodonor. Any child of a patient would also have a 100% chance of being a haplodonor. So very easy to find these haplodonors in families. We prefer right now, in terms of the order of the best transplant option, to utilize HLA identical siblings as their best option, because the risk of graft versus host disease, a complication where the immune cells attack normal tissues, is the lowest with sibling donors. But the data with perfectly matched unrelated donors is now approximating that from HLA identical siblings. And these alternative transplants from HLA haploidentical donors, as well as cord blood transplant recipients, and even mismatched unrelated donors, are improving every year. And we're starting to see now that it's getting harder and harder to actually make a distinction between what is the best donor type. The good news is that almost everybody that needs a transplant now, because we have all these options for different stem cell sources, will be able to find a stem cell donor. Haplotransplants, the biggest advantage is that we can find a relative that's a half match for most people. The disadvantage of this approach is that these types of patients need to receive chemotherapy with cyclophosphamide after the transplant to kill any of the immune cells that would cause graft versus host disease. But that chemotherapy, or called post-transplant cyclophosphamide, is highly effective in preventing graft versus host disease. This is a very standard approach now. We know that haploidentical transplants with post-transplant cyclophosphamide have similar outcome to matched unrelated donor transplants, just comparing the two. 5 years ago, most people would have said a matched unrelated donor transplant was preferable to a haplotransplant. Now the data really suggests that outcome is comparable between the two. Cord transplants, the big advantage with them is they're an off-the-shelf source of hematopoietic progenitor cells in a significant proportion of patients that don't have a matched unrelated donor or a matched sibling donor. 60 to 80% will have a cord blood unit that would be adequate to use as a stem cell source. There was a recent trial that did a head-to-head comparison of haplotransplants versus cord transplants in patients with AML. And that data showed an advantage from a survival perspective with the haplo donors compared to the cord donors, mostly because the cord donors had a higher risk of transplant-related mortality, mostly from infection. So most people would consider a haplotransplant as being potentially a preferred choice of stem cells compared to cord based on the study result. The number of cord transplants done in this country in adults every year has decreased since the study was published a couple of years ago. So my last slide is just to say that if you're potentially considering an allotransplant, it's important to answer the following questions. The first is the potential benefit of the transplant, does that justify the risk of the procedure? An allogeneic transplant can have a risk of transplant-related mortality in the range of 10 to 20%. So it's important to decide, is the patient a good candidate for the procedure? The younger the patient, the better. Even though we can do allotransplants in patients over the age of 65, patients that have any medical comorbidity are at increased risk for transplant complications that could potentially be fatal. The second question is the disease that you're doing the transplant for controlled sufficiently to where a transplant would help? Timing is everything with these allotransplants. If you have AML, it's really important that you go to the transplant when you're in remission. If you have a first CR, first remission, that's a great time to go to a transplant because the risk of relapse is the lowest. If you relapse with AML after chemotherapy, then it's very important to get hopefully back into a remission before the transplant. In patients that get chemotherapy that go into remission, very important to try to time that allotransplant, within 2 to 6 weeks of that salvage chemotherapy, so that you're putting them through the procedure before that disease would relapse, which would obviously decrease the odds of curing them. Do you have a stem cell donor? We know now most patients will have a stem cell donor because we can do cord transplants and haplotransplants. And then the final, probably most important thing to ask is, what are the chances that I could actually be harmed by the transplant? Am I healthy enough to go through the procedure? Or do I have all kinds of medical comorbidities from chemotherapy, like liver problems or heart problems or lung problems that would make a transplant risky? Am I young enough? And young is a term that's continually evolving. Young enough 25 years ago was under the age of 55. Now we're doing transplants in patients 70 years or older. So that's much less of an excluder. And then really, very importantly, what are the pros and cons of other safer non-transplant treatment options? So if you have a disease like CLL and you have a 17p53 mutation, 17p deletion, the BTK inhibitors are highly effective in managing this disease with virtually no risk of regimen-related mortality. So transplants for these types of patients are reserved for those that are failing conventional targeted therapies, where a transplant can still be curative even if you relapse. But you would not want to put somebody through a transplant if a pill a day, a BTK inhibitor would be sufficient to control their disease, potentially for the rest of their life. So I will stop there and thank you all for your attention.